When you get a diagnosis of cancer, what matters to you most? Many patients say, of course, that I get the care, the treatment that I need. Much later, when they look back, you often hear, look, I was surprised how quickly I developed anxiety, depression, psychiatric symptoms. And the good news is the data tells us support groups work. They work very well for many patients. The opportunity to share with others, to learn from them. The bad news is some patients, they just don't show up. They don't want to go there. And that's especially true for young adults, for teenagers. There are many reasons. I discussed them with Dr. Asher Marks from Yale Medicine. And he found a way to bring them to these support groups by using virtual reality. So they can choose their avatar, and it makes it a lot easier for young people to join these support groups and help others, but also grow themselves. So cancer treatment is a lot more than giving people the right medication, the right medical intervention. It's also a lot about making sense and giving meaning to what's happening, and that helps. And that happens with others. I have with me Dr. Asher Marks. You're a hematologist, oncologist, and director of pediatric neuro-oncology at Yale Medicine, and you're co-founder of XR Hi. Hey, Asher, how are you?
Hey, good. How you doing? Thanks for having me.
Yeah, it's brilliant to have you. And XR just in one sentence, what sounds amazing. What is that?
Yeah, so XRPEDS is our initiative in the section of pediatrics over at Yale to explore kind of use, safety, and efficacy of extended reality technologies, specifically for the pediatric population. You know, these are technologies that we know are coming, and we want to be ready for them. We want to make sure that kids have access to the good and are shielded from the bad. So that's what we do.
So you're an oncologist. Your job is to help people, ideally heal people who have cancer. How does extended reality, AR, VR, play into that?
Yeah, it's a great question and one that needs to be answered. So how did I get to where I am here? So a few years ago, we started an initiative specifically focused on adolescents and young adults with cancer. They are a underserved population. Their survival rates are not as good as their younger counterparts or their older counterparts. And as an oncologist, you know, we are always, you know, seeking that kind of holy grail of research, which is cure cancer. And that's something that takes a long time. And we, you know, we've launched our clinical trials. I'm running a national trial for specific specific adolescent and young adult brain tumors. But like I said, that's going to take a long time. And we realized that this population was also in a lot of need of some real psychosocial support. It's very clear that support groups are something that they were asking for. They wanted to be in groups with their peers, other adolescents and young adults with cancer. And we thought that would be an easy lift. And it turned out it was not. You know, the patients did not want to come back to the hospital for the groups. They were not feeling the best. They didn't feel like they were looking their best. They didn't want to be on camera. Zoom wasn't a great option. And back when we started exploring this,
Sorry if I jump in, just so I understand well. So I try to put myself into the shoes of, like, what's the age? What's a typical age? A teenager?
I'd say, you know, our population falls between about 13 and 25 years old.
So maybe a 16-year-old who has cancer, and then that can lead to psychiatric symptoms. What's the
Absolutely,
issue?
yeah. Depression, anxiety, very common.
So, and then they want support, you offer it, but they didn't come to the hospital. What exactly was stopping them to get the support in peer groups?
Lots of things, right? So we're able to kind of capture them at their appointments with their social worker. We're able to capture them with their psychologists. When it comes to trying to get them to come outside office hours for peer support groups, they didn't want to, and it's understandable, right? They don't want to be back in the hospital, someplace that has very, you know, bad emotions associated with it. They did not want to be physically in the same room necessarily with their peers because they're young. They want to look young, feel young, and being there with, you know, hair loss and weight loss and pale skin. They didn't want to be seen that way. That's not how they view themselves. that combined with the fact that they are living their lives, they have jobs, they have families, they have school. So all of these things combined were reasons that they did not want to come back for these actual, peer support groups.
And then do we know how well these support groups work? I mean, are they just a nice to have, or do they actually improve mental health?
No, it's well documented that not just in chronic diseases, acute diseases in general in this population, but specifically with young adults with cancer, these peer groups can decrease depression, decrease anxiety. They can even increase overall survival through improving compliance with their home medications. So they're actually a very effective part of supportive care for these patients.
So they should go to the groups. They want to. They don't. You tried out what, VR? What exactly did you try?
Yeah. So at the time this was happening, the technology was at a point that we had our, Oculus Rift, we had our large Alienware towers, we had our, 4 camera setups with the HTC Vive. It was too much to really hope for at that time, but we knew that it was going to take some time to get these groups going. And it was clear that what was coming down the line was standalone headsets. And that was a real breakthrough for the interventions we wanted. So we got our hands on some Oculus Quests. Quite frankly, using very little money, which is always a challenge in research. You always want to do things, as cheaply as possible. And we were able to grab headsets for $300 to $400 a pop. Sent 4 patients home with these headsets, had another headset for our social worker, teamed up with Foretel, a group out of New York City that specializes in social VR. And from their homes and from their hospital beds, patients were able to join a virtual room, and our social worker able to run these groups. And so it was a big kind of breakthrough for us that we were able to get these patients in rooms, virtual rooms. They could choose their avatars, look how they wanted to look, and really, engage each other. And it's been exciting and successful, and has continued to grow from there.
Which were the most popular avatars?
Yeah, it's a great question. The avatars that we started with, several years ago were quite basic, right? So they could choose skin color, they can choose hairstyle, they can choose glasses. And it was interesting to watch patients choose to either look like themselves or take on kind of alternative looks, funky hairstyles, sunglasses, things like that. And as these avatars have evolved, we've seen quite a range from patients really trying to model what they actually look like, to really kind of getting out there with different hair colors and things like that. So the software right now utilizes Ready Player Me models, which have lots of customization. I think we'll also be incorporating some meta-specific models. But as time goes on, the avatars that are chosen are getting more and more complex and detailed. So it's been a fascinating experience to watch.
Instead of having 4 young adults sit in one room with a social worker, these 5 people had avatars and they met in virtual reality. What was the outcome? Did it work? How well did it work?
Yeah, so our goal with this was quite simple, right? And what we wanted to find out was quite simple. Does it work, right? Can we get it to work? What kind of hurdles are we going to meet in the future? Because it's clear that this is going to be a technology that's going to permeate everything. And so what we found was that from going from essentially a 0% attendance rate, we had about a 70% participation rate on average in every group. And the goal was to get these groups to meet once a week. We were able to pull that off about 60% of the time, week over week. We had, 60% success to run the group. And we only had, I think it was about 20% incidence of having to postpone the group more than 2 weeks. So we've had fantastic participation. In looking at some early measures of depression, anxiety, and resilience, we've had a statistically significant improvement in resilience using verified measures. And most importantly, we've had patients ask for more sessions. So they've been excited about it. They've wanted to participate. And we've actually seen some true kind of objective improvements, particularly when it comes to resilience. And that's exciting. It means that we're doing good by our patients, and it's a technology that is usable.
And when you think of statistics, cancer is not very frequent among younger people. It just, the older we get, the more like, so chances are you will be the only kid or in your high school with a diagnosis.
Yeah, that's absolutely right. So some of my previous research has been in disparities and what causes certain patients to receive less than optimal cancer care. And while you have the socioeconomic and you have the access issues in terms of insurance and all that, the other interesting thing that you find is actually geographic location to a cancer center. So patients living in less populated, less dense areas, more rural areas, are not getting the care that they need. And that is a vicinity issue to getting to the hospital. And when we kind of extrapolate that to the psychosocial support, that holds true. If they're living further from a major metropolitan area and they have a more rare disease, which adolescent young adult cancer is, they're going to have less likelihood of being able to participate in these groups. So the further they live and the less common the disease is, the less access they'll have to support groups. And so while we do this with adolescents with cancer, it says a lot about what we may be able to do with even more rare diseases and getting them involved in people that they can relate to.
I have a couple of friends who work in medical research, and they tell me about the proposals they have to write in order to do a project just like this. And I was wondering, how easy or hard is it to get an intervention as an oncologist, intervention approved, which uses no molecules, but instead VR? How easy or hard is that?
It's, there are ways to go about doing psychosocial experiments, but not necessarily in cancer centers. And so and it wasn't so much that component, it was the technology component, right? This is a new technology, and anything new is scary and comes with risk. And so to get a general clinical trial going at a major institute like Yale, you've got to go through two major review committees: protocol review, which looks at the science, and IRB, which looks at safety for patients. And I've sat on both these committees, and phase 1 drugs that have never been used in patients before, they'll move through these committee in weeks. The meeting to discuss them takes 15 minutes. Voting is very quick. This proposal took about 9 months before we had it initially in front of these committees, until we had it to the point that we were able to explain the technology in a way that they were comfortable with. And able to get assurances that we understood what we were doing, we understood the technology, and we're taking safety protocols. The safety protocols just had never been in place. And so it was a fascinating process just to get this through those very basic committees that often take very quick.
So it could have been easier to just give them cannabis and get that through the committee.
Yeah, I mean, I've seen, drugs with a litany of side effects move through much quicker because we know how to mitigate them. We know what to look for. But this was a very new situation where we're looking at not only, potential nausea and eye strain components, but also, psychosocial mental components. What happens when you have patients remotely in remote areas, but they feel like they are actually in a place that can trigger, some very serious emotions? How do you make sure that they're safe? And how do you get in touch with them if they drop out and things like that? So a lot to think about that fortunately the process has made us think about and make sure we had those guardrails in place.
If this works with young adults who have cancer, who else could benefit?
Yeah, it's been exciting exploring that, and we've already got other trials up and going. So one of our patients was a transgendered woman, and that just gave us, this idea of wow, she is really enjoying it. She gave us phenomenal feedback, and we have a really well respected gender center at Yale, and we went to them, and they've been very excited about this. We've been running our gender clinic support groups with them. And so these are patients that kind of run the gambit on the gender spectrum and as to how they identify, and the ability to really customize their avatars as to how they feel they're most authentic, and to actually modulate voice if we want, along the spectrum, has been wonderful for them. We're not really ready to talk about any results, but I can tell you they've been thrilled with it and extremely excited, and those groups are going very, very well. So that's been one group. And then moving into the more older populations, metastatic cancers, patients that are coming in with depression, anxiety, understandable fear of death. And then let's see, diabetes populations where we can actually integrate some VR exercises. So really just, exploring the use cases with this has been so much fun. And the support we've been getting from our co-pediatricians has been really exciting.
I spoke to one of your colleagues in the wider sense, Dr. Greenleaf at Stanford University, and he explained to me, look, there's a great place for VR if you want a fully immersive experience where you block out reality. But then there's so much more when you think of augmented reality, different technologies. What else do you see? Where else do you see applications in medicine and oncology?
Yeah, it's interesting. It varies week by week. Some weeks I'm like, VR is a stopgap until we get to the area that we really want. And I was like, well, no, it's got its use cases. There are times that you want to immerse in, right? You want to immerse a patient in that. AR is a wonderful use case when you're looking for intimacy, when you want to put somebody else in a comfortable space in your home, and you can't do that. The use case I always bring up for augmented reality is I cannot wait until we've got solid, reliable augmented reality headsets to put patients, friends, and family in their hospital room when they're otherwise being isolated. It's one thing to have a Zoom call with a family member or a sibling. It's another to have that sibling feel like they're in that room with you, and you add in mixed reality and actually be able to sit there and play with you, in your room. It just adds so much to the mental health of our patients, which ultimately leads to better physical outcomes. So I think augmented reality is where this is all headed, and we are really looking forward to 2023 and 24 and seeing where things continue to lead.
Now, with augmented reality, it feels almost like, well, the Holy Grail is just 2 years away, and then 2 years later, it's just 2 years away. What's out there that you can use today? Think of applications like Beam or others. What space is there for what works today?
Beam has given us, fantastic ideas about where we want to go with this. Beam is a phenomenal way to, have that interaction with somebody in the same space as you, and it's there's something about seeing a someone you have a relationship with, or even someone, fantastical, someone that's famous, in your space. There's something there about feeling that presence that you cannot do through a Zoom call, or frankly through a simulated avatar in VR. It actually lets you get that person in your space, and that's significant. We're really looking forward to working more with Beam and other augmented reality solutions and getting them in the hospital.
Now, that intimacy that benefits any conversation, but how might that be particularly helpful for people who suffer cancer?
Yeah. So the example I like to use quite often is our patients that have received bone marrow transplants. So a bone marrow transplant is something that we do only in dire situations when we need to give such high doses of chemotherapy that it completely wipes out the bone marrow being the source of your immune system. And so once someone is without an immune system, we really need to keep them in the hospital until we reconstitute that immune system. And that can take months. So that results in patients in isolation for a month or more. And they can't leave the room. They're in a positive pressure room that they can't leave. And so to be able to bring family members into that space, to make them feel like they are not alone in there, that's a big deal. And it's a problem now with a solution, and it's exciting.
I have a couple of friends who are oncologists by coincidence, and they talk a lot about medications. Oh, and there's a new molecule, and we might get to a pill. And when I listen to you, I get the impression that connection, a sense of intimate connection, can be as powerful as medicine. Is connection and communication medicine?
In a lot of ways, it is. It's medicine in the metaphorical spiritual sense, but as someone who lives and dies by numbers, we also know that those connections can improve the overall way someone feels, and that improvement can increase activity, and that increased activity can improve physical health. It can improve compliance with medications when you feel heard, when you feel seen. And so absolutely, it's a medicine in both a spiritual and a very true physical sense as well.
Asher, thank you so much for connecting with me today, and thanks for your hard work on behalf of all those patients. And have a brilliant afternoon. Thank you, Asha.